Everyone, we are going to get started with our next session. It is my great honor to introduce three amazing surgeons, Dr. Glenn Pfeffer, Dr. Paul Toulousan, and Dr. Tyler Gonzalez. And they are here with us to talk about surgical options and outcomes for CMT.
So I was sitting in the office about 2 weeks ago. I told the physician assistant that I'm working with about this talk, and we were looking through ChatGPT and seeing how it worked. And he goes, let's just see how good ChatGPT is. And he said, make an impressionist painting of a CMT foot. I don't know, that's not bad. Do you see the slide? Oh, you see it there. Today we have a very excellent session with two other august speakers with us. Now let's see, my picture's in the way there. That's fine. Well, Dr. Gonzalez, many of you know, he's an associate professor, thank you, at the University of South Carolina in Lexington. And he'll be talking about surgical correction. And then Paul Toulousan is at the University of Michigan. I think many of you know him. He's an associate professor in Ann Arbor. Many people say, what should I look for in my surgeon? And I'm going to discuss that later. But I think the main thing you have to try to figure out is, does your surgeon love CMT surgery and CMT patients? That's the key. Actually, maybe to everything in life, right? Okay, let's see what we got. This was the first slide that I gave ever at a CMT talk. Oh, it was maybe at the CMTA. Oh, maybe it was 13 years ago in Los Angeles. And I wanted to get in front of the crowd and not make people think I was a knife-happy surgeon and that I wanted to operate on everyone. So this slide, it's the first slide I put up. And the slide, do you see it? Well, mine's advancing. Oh, there. Good. I see. I was looking at the wrong thing. Well, I'm glad I gave you an introduction. And what this meant is one day CMT will be cured, and you're not going to need me anymore, just like the polio surgeons. And I said, but that day is not here yet. And right now, some of the best things that can be done for a certain subset of CMT patients is surgery. They could markedly change the quality of one's life. But one day we won't be needed. But for now and for, I think, a long time to come. Now, who are we talking about in this session? Many people, many of you know, are very weak below the knee. And you're in a wheelchair. Maybe you have to use a walker. We're not talking about you. There's nothing surgically that we could really add. We're talking about people with high arches, but 20% of people have just complete paralysis, and they below the knee, and they do beautifully in braces. Many, many people do well in braces, and there's no role for surgery. So if your foot's flat on the ground and you're paralyzed below the knee, you can do just great with the ever-accelerating brace quality that's coming out. So what we're talking about today is the 80% of patients that look like that. That's a cavovarus foot, a high-arched foot, or what I've called for 30 years of my talks, a crooked foot. And the crooked foot is unforgiving, with no shock absorption, and is painful. And that's what our topic is really on. It's the 80% of patients who have this. And there's a big variation. Some of you will look at these x-rays and go, well, I'm not, or these pictures and say, I'm not that bad. Well, of course not. The CMT cavovarus feet are as different as the people that own them. But there's something, I think, in this for everybody. So let's see if that's it. I would just encourage everyone to look at this site, Charcot-Marie-Tooth surgery. On Instagram. It started out with one post by me with no followers, 14 views. Now we have 21,000 followers. And in the past few months, one of the views had 6 million views. Now, those are not all CMT patients all over the world, but it's certainly good, isn't it, for CMT if 6 million people around the world are looking at it. Some of them say on their messages, what's CMT? But that's good. It's exposing them. So I'd really encourage this. My wife always tells me to say this, and I'm going to say it, because I do a lot of video chats on Sunday for free with people, but I'm an employee at Cedars-Sinai Medical Center. I'm not getting paid for this. If I operate on 20 more people next year, I'm not going to get paid more. So this is not about that. And when I show you my Instagram, it's not about, oh, good, I can have more patients, to do more surgery. We like to operate, all of us. But it's important you know that. Now let's just see. I think that's it. And let's begin with Dr. Toulousan talking about what causes CMT. It's a complicated issue of muscle imbalance.
All right. Well, thanks so much for having me. And first time I've come to this meeting, and it's really nice to see the really big attendance and how excited everybody is. So getting my slides up here. All right. So I'm Paul Toulousan. I'm at the University of Michigan over in Ann Arbor. And just kind of a brief review thing, CMT, it's the prevalence of it, it's about 1 in every 2,500 people. And as discussed today, it's the most common inherited neurologic disease. One of the interesting things about it is it affects nerves, certain nerves differently than others. And so what we'll see is like a motor issue more than a sensory issue, which means you're more of a weakness issue rather than issues with sensation. And so the way it kind of starts is, I could go for hours about talking about this, but essentially what happens is the nerves start to lose function. When the nerves lose function, they can no longer power the muscles in the leg, and then the muscles become weak. The muscles don't all just become weak in the same way. The muscles on like the back of the leg become weak, but they still keep some of their strength, whereas the muscles on the front and the side of the ankle and the leg, those are the ones that really become weak. And what that results in is imbalance of the muscles. And that's when we'll start to see the foot become crooked or see some deformities. And so if a patient's standing up, and you draw a line from the knee down the front of the shin to the floor, the foot should be essentially perpendicular so that it can hit the ground well. But when the nerves stop working and the muscles become imbalanced, then we'll start to see some deformities. And so the classic Charcot-Marie-Tooth, everybody's a little bit different, but in the classic sense, we'll start to see the foot supinate or tilt inwards. And a patient like this will start really loading the lateral part of the foot, or the pinky toe side of the foot is one of the issues we'll see. Drawing that same line from the knee down to the ground, the back of the heel should be lined up like to the outside of that line. And with the muscle imbalance, the foot gets pulled inward, the heel gets pulled inward, and now it's resting to the inside of that line. And then as we all know, we get the classic changes with the high arches, and if you look at the toes on this person, we see like claw toes, or the toes are starting to scrunch up. To get into like a little more detail about what a foot and ankle orthopedic surgeon, what nerves do we care about? So the sciatic nerve, it runs down the back of the thigh, and then right behind the knee, that nerve will split into two, and it becomes the tibial nerve and the peroneal nerve. And so the tibial nerve, that lives on the back of the leg, and that gives power, and that the nerve goes to the muscles like the calf muscles. So those are the muscles that point your foot and ankle downwards, and that remains strong, as well as the muscles that turn the foot inwards. The nerve that doesn't work very well is the peroneal nerve, and that's on the front of the leg. So the muscles like the tibialis anterior, so that's the muscle that brings the whole foot and ankle up towards to point up towards your head. The peroneus brevis, which turns the foot outwards, gets very weak or just completely paralyzed, as well as the peroneus longus, which doesn't lose as much strength as the peroneus brevis. But these muscles do get very weak, and that's when we really start to see the deformity. On an X-ray, so this is on the left side, this is a person who does not have CMT, so drawing that line from the knee down the shin to the floor, the foot is resting nice and perpendicular to the floor. The patient with CMT, you can see that the foot is really tilted inwards. This person is walking on the lateral side of the foot, or the pinky toe side of the foot, and this is all due to the muscle imbalance from the Charcot-Marie-Tooth disease. Other things we'll see, so if the muscles on the front of your ankle are like completely paralyzed and we lose function of the tibialis anterior, we'll get foot drop. This is a pretty dramatic example of that, where the patient just cannot bring their foot up towards their head at all, and the toes as well. And then in order to walk around and not trip over this foot, they people will develop something called a steppage gait, where you're almost marching around and the foot is kind of slapping on the ground. And then if this is affecting 2 feet, this is a pretty big fall risk. Other things that other problems the imbalance is going to cause. So when the foot is tilted, you have the tendency to roll the ankle, and you have multiple sprains of the ankle, and ultimately someone can end up with chronic instability of the ankle, where the ankle just feels very loose and sloppy. And then other places we'll see bony prominences, and those bony prominences, they rub on the ground, they rub in shoes. We'll see big calluses like this. And then because the foot is tilted, and we're really loading the lateral part of the foot, or the pinky toe side of the foot, you can just get a lot of pain there all the time with every step you take, and that's what we call lateral column overload. And if it progresses even further, we'll see things like stress fractures, where you even start breaking the bones on the side of your foot. Other things we'll see, so the Achilles tendon can end up getting very, very tight. And even if the foot can move, if the Achilles tendon is really tight, you can't really get the foot to 90 degrees, and then you end up kind of walking on the tiptoes to get around, and that can be a problem. And also that'll end up hurting the balls of the feet. And then because the tendons on the top of the foot are not working very well, but the tendons on the bottom of the toes are working decently well, the toes sort of lose the tug of war, and they start to develop mallet toes and claw toes or hammer toes, where the toes are really scrunched up, and then the toes can rub on the top of shoes, or the tips of the toes are sort of hitting the ground, and you can get a lot of calluses and pain in the tips of the toes. So I'm not going to go into the details of surgery. That's what Dr. Gonzalez is going to do, but the goal of what we're trying to do is we want a foot that hits the ground in a more balanced way. And so are there patients that we're going to get to a point where they never have to wear braces and they never have to wear inserts? Absolutely. We'll get some patients there, but definitely not everybody. There are other patients where after surgery, get them to a point where, if they're walking barefoot on hardwood, it hurts, but once you get some inserts under the feet, and so you're walking around in shoes or slippers or something, then they're good to go. And then in other cases, if someone has a foot that just is too crooked and stuck, and it cannot tolerate a brace at all, and sometimes the best we can do is get a foot to a point where, like, now you can tolerate a brace. And what makes us happy as surgeons is it's not necessarily that we didn't give everybody a normal foot, but to hear that we made a big change, and now even if you're in a brace all the time, you can walk way better than you could before, and that's what keeps us coming back. And as far as who will have better results, or what determines what kind of result we're going to get, it has a lot to do with the severity of the CMT disease that we're started with, and the degree of deformity. As far as treating things without surgery, as Dr. Pfeffer had mentioned, orthotics are great, but they can only go so far. Things like AFO braces are great for foot drop to help prevent people from tripping over their feet. ASO braces are like lace-up braces, good for ankle instability. And then things like physical therapy, which we kind of heard about before. We're trying to squeeze every drop of juice out of keeping muscle strength. And I'd say that one of the bigger things that really resonates with me is trying to prevent a foot from getting too stiff. It's too stiff and too stuck, because that can affect sort of our treatment options. Well, I really appreciate the opportunity to be here. This is our appointment line, which you could take a picture of or Google it. And then we also have a CMT clinic at the University of Michigan, which I think we heard from Dr. Gallagher earlier, and they have a great program too. So thank you for the opportunity, and thanks so much.
All right, good afternoon, everybody. My name's Tyler Gonzalez. I'm at University of South Carolina. Know a lot of you here, and so thanks for having me. Well, I guess you get the first thank you, Dr. Pfeffer. There was a CMTA thank you slide, but somebody took that out. So first I want to thank the CMTA for having me. It's a real honor to be here. I've worked with them almost for a decade now because of Glenn. So I wanted to thank you for having me. It's a great honor. And I wanted to thank...
Scary, isn't it?
That is him mopping the floor. So I want to thank Glenn. Glenn is the one who got me into CMT almost a decade ago. I trained with him at Cedars. And as you said earlier, I fell in love with it. And part of this talk is going to be why. And this was us after a big case. And, you know, you see Dr. Pfeffer grabs the mop, starts cleaning the floor. And he always wants to keep moving, keep progressing, keep innovating. And I think for CMT surgery, we're here today because of him and what he's taught us and got us. So just thank you for getting me involved. So this is the CMT, classic CMT foot, right? As Paul and Glenn had said. And it's, how did this happen, right? How did we get there? And Paul talked about it. I'm going to briefly go through a few things just so you can understand how we fix this. So oftentimes, because CMT is a progressive motor sensory neuropathy, it starts subtly, high arch feet, slight weakness, and then we go into progressive weakness, atrophy, foot deformity, foot drop, paralysis, and even sensory loss, and even pain. So something may start off as simple as this, where you can see on the left side there may be a slight turning in the heel, but over time you can end in something like this. And there's a surgery corrected on the right and her residual, or on the left and on the right. And you can see on this side her heel turning in the high arch foot and the hammer toes. So why does this happen? Well, Paul just gave a great lecture about why. It's an imbalance, right? It is imbalance between strong and weak muscles that causes these deformities. So when you see here the foot turned in, this is because you have a weak muscle on the outside and a strong one on the inside, which causes the heel to turn in. Here you have a weak muscle that pulls the foot up and a strong one that pulls some of the toes down and the arch down, but also pulls the toes up. This creates kind of that high arch foot and that toe pointing down, and also leads to these hammer toes, as Glenn and Paul discussed. So these are all things that we want to address, and can we fix these? And every time I see a CMT patient, when I trained with Dr. Pfeffer, the question is, yes, we can fix it, but how? Well, we have to reroute things. We reroute the tendons that are strong and that work, and we rebuild the bones of the foot. And that way we fix the foot shape and put what's strong where it needs to be. And we do this with surgery. So braces are great in certain situations, but our surgeries have come a very long way. We can't cure your CMT, but what we can do is make you function better, make you, have better activity, as well as fit better into certain braces. So the goals of surgery: obtain a plantar-grade foot that you could wear a shoe, pain relief, and then preserve motion if possible. That may not always be the case, but it's usually possible. So we need to accomplish the main things and I always tell CMT patients, no one is ever the same, and both your feet, they're brother, sister. They're not twins. So every case is different. So whenever I see patients from all over the state or country, we can do virtual visit, but I need to get my hands on your feet to see. But overall, we want to address foot drop, loss, the hammer toes to a degree, the foot turning in, and the high arch. So just for anyone in the audience, I am going to show some surgery pictures. So if you're weary of blood or incisions, they're not too gory, but they're coming up. So this is what got me interested in CMT. This is one of Dr. Pfeffer's patients. This is where I fell in love, because this is a life-changing surgery. We do a lot of good work in foot and ankle surgeons, but in CMT, we really change people's lives. And this is one of Dr. Pfeffer's patients, this young lady, and this is her after. So not able to wear shoes, function. I mean, this is what got me sold. And so this is one of my patients who had multiple surgeries and came to see me, 20 years old, couldn't go to college, had to drop out because of pain, had persistent, he had multiple surgeries on each foot for his CMT. He came in a wheelchair, and you can see his mom's in front of him. He can barely walk. His feet can't move, and this is how he steps, and he usually had to drop out of college. And so I revised both of his feet, and now he works as a prison guard, and this is him. right? And so this is not after doing one like he had multiple surgeries even before getting to me. So if we can get even earlier, we could avoid this, but we were still able to fix him and get him walking, and now he's a prison guard, finished college, all of those things. This is another one of my patients. She showed me this picture on the phone. This is her at a rock concert in a mosh pit. And she's like dancing in my office, and all she wanted to do was get back to going to concerts, but she was too unstable. And this is her 5 months after her CMT reconstruction. So how do we address this? I got about 3 minutes left, and we're going to do it. So the first thing is we got to take the tendon that's pulling the foot in to now pull the foot up. So we reroute that tendon. Be wary. So we make some small incisions and put that tendon to the top of the foot. Here's one of my patients who is now 6 months out from that surgery. We did a big reconstruction, but this is what it does. It works, and it pulls the foot up and out now. So it's no longer pulling it down and in, and it works very well. Then we have to address the hammer toes often, not always, but if they cause a problem. This is a patient of Dr. Pfeffer's we actually did together. The feet looked very similar. We corrected the one on the left, but I wanted to show you this picture to see the one on the right. So in surgery, we often take those tendons, and instead of pulling up the toes, we move them to pull up the top of the foot. And then on the left, on your right, you can see what it looks like. So we correct the hammer toes, but also give them more power. So how do we correct the heel turning in the high arch? So this is one of my patients. These are her x-rays. You can see a very high arch. So to correct the bone on the heel, we cut the heel and shift it over. So we move it to be better in line with the floor. We move it. We cut it in, we shift it, and then we fix it with screws. And we can do this through small incisions, and you can see here the heel corrected on the left and her persistent CMT foot on the right. So we can really do a good correction of that heel by moving it over. This is a great animation Dr. Pfeffer made several years ago showing, well, how do we drop the arch? Well, we actually can cut the bone and drop the arch as well. This is another patient of mine who had surgery in New York but had recurrent heel turning in, recurrent high arch. As you can see, her arch is still very elevated, and foot drop. So I had to redo this. So what we did is we redid it. We recut her heel and slid it over. We did a tendon transfer of that post-tib, and then I cut her bone and dropped her arch. And as you can see here, we were really able to drop her arch and get her in a better position there. So what happens if your joints are stiff or you have bad arthritis or they don't move? As Dr. Toulousan alluded to, this can happen. You can't always, sometimes you do need a fusion of the foot. So this is the kid I showed you in the beginning, really rigid foot, couldn't move it, terrible arthritis, and he can't even get his foot on the ground. So I did what's called a triple arthrodesis, where I fused some bones in the foot to get the foot nice and straight and on the ground. And here's the correction on the x-rays, just giving him a foot that he can actually walk on. And as I showed before, he can walk 50 yards now in the time it takes him to take one step on one foot with the help of his mom. And that's why I love CMT, because you can really change people's lives with these surgeries. So here's just another example of a pre and a post-op of what we can do to the shape of the foot. And again, another one of my patients here on the left, post-op right, where we correct the heel, get their foot nice on the ground, and drop that arch. So what's next? Well, several years ago, Dr. Pfeffer created the CMT think tank, which was supported by the CMTA, where we came out with our consensus statement for surgery, which I think is a great paper everyone should read. We continue to need to do registry and database to find the best care. So I want to thank everyone, CMTA, Glenn, Paul, for having me. Here's my cell phone, email. Please feel free to text or call me with any questions. Reach out to the CMTA, and thank you all very much. 2 minutes over.
Well, I'd never heard these guys talk about CMT, and it's a real pleasure to be on the stage with excellent speakers. Thank you. I'm just going to go scroll through to where I started. I wanted to have questions, but sometimes people ask questions that don't help the whole audience. So I actually polled some people ahead of time and said, what questions do you have? And one question that consistently came up was this. what's the point of doing surgery? It's a progressive disease. Why? You know? And I think we'd all agree, just briefly, is what I say to my patients is, look, you're at a C- right now, a D. And if you get worse, you'll end up with an F, right? Or even thrown out of school. But if we correct your foot and create a foot like Paul can do or Tyler or I can do that's flat on the ground and the ankle's stable, ideally going up and down, even if you become completely paralyzed below the knee, you still have a foot that'll go from a B plus A minus at least down to a B. And I've been seeing patients here the past few days, and it's been disheartening to me because so many people could have done that and for one reason or another didn't, you know. It's hard to do surgery when you're just getting by. But I think that's the most common question I see. Okay, let me go scroll through to where we were, and then we'll start. So I changed my talk. A remarkable thing happened to me last week. I was in the office with 7 CMT patients all at once, from all over the United States, one from California. And I asked them all, what should I talk about? And I had a very consistent answer. They all said, speak from your heart. I don't know what that exactly means, but I did change my talk. And we'll see where this goes, the heart business. Okay, so the question really comes up is, when do you need surgery? That's something that these guys have alluded to. And again, I've seen people with feet just as bad, if not worse, as either of them showed, and they go, but I'm getting by fine. Then don't do surgery, you know. If you can go like that and fix your feet, everybody would. But it takes a lot, right? But when would you do it? If your braces are uncomfortable, right? If your feet look like that, in your braces. If you're not in braces and you're spraining your ankle and maybe you buy a simple $15 brace from Walgreens and it doesn't work, right? Or if you're walking on your toes. And then the last that I put in red is maybe you don't want to wear braces. A very common group of patients I see are 15, 16-year-olds who say, Dr. Pfeffer, I'm going to college in 2 years and I'm not wearing braces in college. And I said, okay, let's work on this. This was Sarah that Tyler was showing. Her parents were fortunate enough to be able to move where they wanted, and they looked all over the country for someone to help them, enthusiastically help them. Look at the bottom of her foot. And you know all Sarah wanted? She just wanted one thing. She said, I want to walk down the high school aisle and accept my diploma without having to hold on to my father. Oh. You know, that's enough to get anyone interested in CMT, especially when she did that. She went on to become a pizza delivery person. She's out of braces. The New York Times didn't, but they wanted to do something on CMT, and I called her up and I said to her, Mom, they might want to interview her. How's she doing? And I was so scared. Hang up. Dr. Pfeffer, get out of my life. You ruined my daughter's life. She said, are you kidding? You know, she's waiting tables. She wants to go to law school. Now, why don't people do surgery then? You know, why don't they? Well, this is what I rewrote. I think CMT patient foot and ankle high arches have the worst care in the United States. Oh, not in Paul or not with Tyler. I can't think of a disease that has such bad care. Because it's one thing for me to say to you, I'm sorry, I don't know what to do with your problem, but I know who does. But instead, that's not what you're told, is it? I have patients of mine here. I'll get on to that. There's nothing to do, I'm sorry. You have to live with it. My neurologist said that there's nothing to do. Let me say now, if the screen is going, I want to say to every neurologist in the United States, tell your patients with crooked feet that they can be operated on. To do otherwise is unconscionable. Many, many neurologists are still treating people as though it's the 1950s. We've come a long way. I was told braces are the only way to go. Braces are great. great. If your foot's flat and they're not uncomfortable, but not if you're suffering with every step. Hogwash, as I say to those three things. If your foot's crooked, you have calluses, you're uncomfortable, maybe you don't want to wear braces, get an operation. But my father was a surgeon. He had a mole removed. He said, I know the difference now between a big operation and a small one. He said, it's big when it's on you. So I get it. I've had 3 surgeries. I dislocated my ankle. My foot's in constant pain on the left, and so I can still do 6-hour surgeries. I may have another surgery. I'm going to find out about this afterward. Something small. I have a callus. So I get it. Promise you, I get it. My surgeon didn't seem confident. Well, that's easy. CMT is scattered through the United States. Even the busiest of surgeons, maybe not these guys, who do 1,000 cases a year, they'll say, oh, I'm busy. I do 3 or 4 or 5 CMT cases a year. I don't know. It's not enough. You can't get experience that way. I had a very remarkable journey with CMT that started 30 years ago, the day I got to Cedars-Sinai, 35 years ago. And the day I got to Cedars-Sinai 20 years ago, I said, I want to set up a foot and ankle center here. And then one thing just stumbled along into the next. So now I've done 1,500 surgeries, and I'm sure that's probably more than most of the surgeons put together. I never wanted it to be that way, but it beautifully happened, and it's been remarkable. So it's hard. How do you find a surgeon? You have to dig. I was worried about postoperative pain. That's completely legitimate. But we did a study on that. The study showed that using a nerve catheter could be very helpful in diminishing the pain. And then I've seen a lot of people here saying, yeah, my feet are crooked, but I'm doing okay. No, that's a hard decision if you're doing okay. That is hard. Let's see. So this is the issue. Who do you trust? How do you trust your surgeon? Well, you have to find out. You need a surgeon who loves CMT. I know Tyler does, and I was talking to Paul afterward. He said, if I could do nothing else but CMT surgery, I'd be happy. That's what I want to hear. All I do is CMT surgery now. We do 2, maybe 3 cases a week. And I couldn't be happier. Find an orthopedic surgeon who does at least 6 a year. That's probably a good number. And you look at them in the eye, and you make sure there's no quivering. The pupils aren't going crazy when they say to you, I can get you better, right? This is the study we did on a little tiny catheter that we put around the nerve that diminishes the pain markedly for 4 or 5 days. Someone came up to recently and they said, we're so glad you did that study. At our university, they don't want to even give nerve blocks to patients. What horrible pain if you don't have a nerve block. There are still major centers that just give general anesthesia. You wake up, good luck. All right.
I am
Listen to this.
a new
This
person.
is profound.
I
just want to start again for a minute. This gal came from Boston. She worked at a major medical center. She came to Cedars. Her feet were bad, but she was living with it. She sent me this several years later from Ireland where she moved. But listen carefully to her words. I think they're some of the most simple but profound things I've heard from a patient. And everyone, including the 3 of us, have something to learn from this.
I am a new person. I didn't realize how bad my feet were and how much it really impacted my quality of life until you've now given me good feet, and I can see what life is like with good feet and how different it is, and how much more I'm able to do. I feel like I've been given really a second shot at life, and I knew it would be life-changing, but I don't think I knew how much. I don't think I knew how bad I was until I now see my life post-surgery.
But isn't that incredible? I didn't know how bad I was until I fixed it. Impairment, someone at the CMTA said, becomes the new normal. That's true for all of us, though. Everything we do in our life, there are things that aren't right that we grow to live with and accept. And afterward, when you've withdrawn from the bad job or whatever it is, you go, gosh, I didn't realize how bad I was. This fellow, he came from up in Northern California. I'll just go it again. He said, I'm told there's nothing to do for my feet. He was 19 at the time. He sent me this email a few years ago now, a year later. He's lifting weights. He started a new job. And it's just the kind of patience that Tyler showed.
My name is Matt Waller. I have lived with CMT for 30 years.
Look at his pre-op
I was
X-ray.
resigned to the fact that I was going to just have to deal with it for the rest of my life. In 2023, I found Dr. Pfeffer's Instagram page, and my wife and I went out and had a meeting with him, and he told me he can fix me. I had always been told I was unfixable. Do not believe that. If you can be fixed, do it. It's life-changing, and you will not regret it.
He came to Cedars. He said, my goal is I want to keep playing golf. I'm a scratch golfer. I said, well, let's cancel the surgery. My goal for you is that you can walk the rest of your life. And he went, oh, and his wife gave him this dirty look. And he goes, yeah, I want to be able to walk, Dr. Pfeffer. Look at his feet before, right? Now he's walking on the beach. You can't expect that necessarily for everybody. Do you know, many of you know her. There's no sound, sir. Why is that?
My right foot reconstruction. My name is Erin, and I came out to Cedars from Pennsylvania to have my right foot reconstructed, and I was really terrified for a really long time. And now, 2 weeks out, and I did it. Everyone here has been so wonderful, and I saw my x-rays today, and I am just surpassed anything I hoped it would be. So I'm really looking forward to getting back to life.
She had waited too long.
What made you wait so long, if I can ask?
Ha, sorry.
I think I waited a long time for fear of pain.
Can you move it up and down? Your left
I was
foot?
just so used to my life. I have a really good life, and I just thought, it's okay, we're just gonna figure it out, and it's just part of my life. And I just think I was in denial or just settling with what I had. And then I just kind of felt like, if I have a shot, why not try it? If it could be better, let's try it.
She said to me before surgery, she said, I'm a happy person. Why should I do this? I do well in my electric wheelchair. Oh, she'd already destroyed her ankle. She'd waited too long. Why? Why would you wait too long? Well, for the reasons I said. It makes sense, right? Maybe it's an insurance issue. You don't trust the doctor. Whatever, fear. To finish up here, it's your kids that I care most about. If you're going to live with what you have for 20 years, then live with it. But do not let your child live with it. Do this for your children. You need to give them a foot that's flat on the ground. I was looking at a video of a gal over here, her 5-year-old's in a brace, the foot's flat, fine, wonderful, but not a crooked foot. Who would tell this person here that there's nothing to do for him? These people are all under 18 that I'm showing you. Who would tell them that? This young man's in braces. He says, I can't really walk, I'm painful, but I'm okay, doc. This is in the surgery area. How does that happen in the United States? That someone wouldn't at least say, well, you might consult with a surgeon. How about these people? They're not braceable. You don't take a crooked foot and put it into a brace, or you end up with a very crooked foot and you're getting by. Look, people live blind, people live with no hands, but this you don't have to live with. How about her? She was 7 at the time. She came from a major university in Boston. They were told there was nothing they can do, and she couldn't even wear a brace because her foot wasn't correctable. Oops, sorry. Let's see, am I out of order? Okay, you saw her. This remarkable woman is here with her child, but her husband got operated the week before.
I came out to California from Kentucky for my son's CMT surgery on his left and right foot. We did the left first. It was a lot being here for 2 weeks, but the happiness that he's had, I told you, since, he's hardly walking yet, but he's doing great, and it's the best thing we could have done.
Why did you wait?
I guess I was probably scared. I didn't want him to go through the pain.
What were his symptoms that he had before surgery?
It was hard for him to walk long distances. He didn't really want to do much. But I'm hoping. He loves to travel, but it was always very hard for us to do a lot and be
He was
walking.
unstable. He was painful. Had he tried braces?
We tried him once, but he never.
Right.
They were never
Because what
comfortable for him.
16-year-old, he's
Yeah.
younger, I think he's 13. What 13-year-old wants to wear a brace? This boy, I'm sorry, there's nothing to do for you? I've saw people in the past day that have a brace like that. If they're doing fine, okay, but don't let your child live your life. If you want to live like that, all right, but it's not as long suffering as your child has to have. Here he is after the first surgery. Here he is walking. Oh, it's not going to show, but that's his foot on the right. This fellow, before surgery, after surgery, you get it.
Come up to meet you, tell you I'm sorry.
He had to walk like this the rest of his life. Young guy, adolescent. He sent me this video recently. How many people in the room would like to be able to do that who have a crooked foot? I can't even do it after my surgeries. And there she is, the gal I showed on the beach. There she is just before surgery. No one wanted to operate on her on the East Coast. And here she is maybe a year later. Do it for your child. Another, the themes are similar. Another. I said to the mother, it's so hard for you to be here. You're taking time away from your family. There's cost. Why are you here? And she said, I'm doing it for my son. That's the answer, right?
Hi, my name is Jack. I'm 11. I have CMT, and I just had both my feet done with surgery. It's not that painful, and I used to have like crooked feet, and I used to keep falling. Yeah.
This was maybe the most touching follow-up video I got from the father. A few years after surgery, she could hardly walk without holding onto the wall. And he said, Dr. Pfeffer, thank you for giving me my daughter back to me. So, I'll conclude. There is risk, right? There is risk. This gal, I'm not going to jump like this. I don't want to. There's nothing in it for me. But if you have a crooked foot and you're painful, there's a lot in it for you. This was Betty Conley, not the bungee jumper, and that's what happened after her surgery, all right? But she said, we're going to get through this. And 2 years later, I got this email from her husband. And she said they're walking on the beach again in North Carolina. Here's what he wrote. I'm just going to read it, if I may. Today is the 6th anniversary of the truly life-giving surgery on my Betty's left ankle. That surgery gave our family the ability to walk our city, hike through Scotland with longtime friends, tour Paris with her beloved aunt, give care to her mother living with Parkinson's, and all the other wonder that Betty spreads throughout the world. Thank you, thank you, thank you. So to conclude, I'll take one of those thank yous. I've gotten good at this after all these years. But the other thank you is for Tyler, my previous fellows who've worked with me, Max Mikalski, Tanya Ahn, Eddie Haupt, who've published the major research that we've done that I think has changed CMT surgery. And the final thank you has to go to the CMTA, both from me and from everyone with CMT and all the surgeons. The first grant we got from the major research that's changed the CMT surgical world was from the CMTA. Elizabeth Ouellette was here. She got very excited about all this. The consensus statement that Tyler was so instrumental in getting together came because of CMTA support. The papers that I've written for them that are all available to you. The goal is to cure CMT, but until then, the CMTA understands that helping people with crooked feet is important. That's led to a host of other research that we've done. This is the long-term follow-up on CMT. It says that people have better mental attitude on life, less pain, and better function. Right? Who wouldn't? Not everybody does well, but as a group, people do great. This was published in the major journal of the Academy. I'll end this talk with the first slide I ever gave to the CMTA, as I told you, but this will have a different interpretation. I may stop operating next year here. Sorry. Damn. Okay, so my wife, she lives in England, her family, and she wants to move closer to them. I'm not sure, but I think I owe it to my patients who've all said to me, we're waiting for the other foot to be done. We're on the sideline. We'll come to you one day. There's time now. But maybe, I'm not 100% sure, I may stop. So if you've been waiting, now's the time to call. Thank you very much.
Thank you, Dr. Pfeffer, Dr. Toulousan, Dr. Gonzalez. Absolutely incredible presentation. You have truly all changed the lives of so many people in the CMT community. Thank you. We don't have time for questions, but I just want to say one last thing. I've been with the CMTA for almost 7.5 years, and these 3 amazing doctors are so incredibly generous with their time. I've never seen anything like it. They are so available to the CMT community. They love the CMTA, and we are beyond grateful to have you all as part of our team, truly, to make life successful with CMT. So thank you for being here.